Sorry. So I'm gonna talk about the middle range theory of self and family management of chronic illness and its applicability on stroke care. So self-care and family management of stroke care gonna be my research topic. So first of all, I'm gonna talk about a little bit history and background of the theory. Aaron's grandson of self-care deficit inspired tons of nursing researches and nursing series development. Self-care series research started to develop since then. Originally, this mid-range theory was a framework created by Gray in 2006. Later on in 2015, Gray with other coworkers revised this framework after tons of LLIs and research LLIs. But after years of research and meta synthesis, citation analysis, and quantitative article reviews, except zero. So in 2023, Schumann, Green, and other coworkers, researchers developed this reverse framework into a mid-range theory. So this theory is very closely relative to the mid-range theory of self-care and chronic illness developed by Dr. Babu Riga, but I'm gonna talk about that too. So this is a original framework developed by Gray in 2006. As you can see, there are some risk and protective factors can be act like the barriers and the facilitators. But the middle one is family management and self-care management. So they affect the factors and outcomes. They act like dynamics. So they are both dynamics affect each other. But in 2015, this framework developed more comprehensive and more in detail after tons of research and analysis. The facilitator barriers, they list like 5 of concepts. In the process part, the learning, take ownership, health promotion, and community resources. So they can affect outcomes, the self-efficacy, cognition part, behavior part, and symptom management. Ultimately, they can affect the digital outcome. They can affect the quality of care and quality of function, relationship with the healthcare providers. So why this is applicable to my research area? There are a few key concept component of the series. So this model is the theory model developed by Schumann, Green. So chronic ELS management may occur between and ideally among patients, self-management, family management, and healthcare professional support. Each of them can lead to personal outcomes, ultimately digital outcomes. Patient, family caregivers, and healthcare professionals process affect each other. So they are, as I said, they are dynamics. So the proximate outcomes include behaviors, cognitions, biomarkers, and system management. The distal outcomes can include health status, individual outcomes, and healthcare resources. So my planned research is self-care and family interventions of stroke patient. The definition of self-care by Dr. Barbarigo is that a naturalistic decision-making process addressing both the intervention and management of chronic illness, which core element of self-care maintenance, self-monitoring, and self-care management. So self-care maintenance, self-care monitoring, self-care management are 3 key concepts listed by Dr. Barbara Riga in her theory. self-care is often thought to be individual behavior, but self-care really is close to family and community, as well as healthcare professionals. Self-care has been studied in many researches since last century. So there's a huge gap, I think, as a bedside stroke nurse. Uh, I see a lot of problems and concerns that worry about me. So I'm going to talk about that in the next slide. Self-care in stroke is not commonly studied during my literature review, but commonly those chronic illness like heart failure, diabetic, and cancers are most studied diseases for self-care research topics. So stroke care are common barriers. So access to the resources, support system, because post-stroke symptoms management can be long-term. They rely to family caregivers, participate with speech therapy, occupational therapy, physical therapies, except they're compliant to medical treatment or not. Usually, some patients lack the resource and educations. They thought they have one stroke and that will be it, but they're gonna have a recurrent stroke, a secondary stroke after that. Relationship with healthcare professionals. As a bedside nurse, I saw that a lot. So, for example, the doctor may prescribe the patient Eliquis for AFib control, but they did not teach the patient to how to take it, how long you should take it, and you should not stop taking Eliquis by yourself. But most of the time, the patient stop taking the Eliquis by themselves, and they get readmitted for the stroke. Uh, After stroke, usually some patients will have the cognition decline, which that can affect the self-care behavior and cognition part. So the leading causes of stroke are atrial fibrillation, hypertension, diabetic. Those three top chronic disease can cost a lot of money and resources. So again, community resource and healthcare professional support are very important for this type of chronic illness. The cost of treatment, for example, Eliquis is extremely expensive, but commonly prescribed for atrial fibrillations. So I think the healthcare professionals here in the United States, most of the time they're falling to their scope of practice and their responsibilities. I think nurses and nurse practitioner can do much better jobs than those of doctors. Pardon me to say, but so last one, financial barriers. This is one of the big part because Eliquis is very expensive. So the doctor sometimes will prescribe that to the patient to go home with, but they do not check their insurance coverage. Sometimes the insurance will cover for that, but sometimes not. So the patient can go 1 month of coupon for the Eliquis, but how about the later on? So what do you think about that part? Patient, family, healthcare professional, and dynamics, each of them affect each other. Family members play significant influence on self-care. Some researchers use the term patient and family partnership. More social network, better self-care, and better outcomes, as listed by Dr. Barbara Rigo in her guidelines on self-care. Healthcare professionals and patients also should work together for CVD and stroke care. This term can be described as a patient-provider partnership. Studies and clinical trials have showed that self-care in patients with stroke can improve activity of daily livings, quality of life, self-efficiency, reduce dependency, and premature deaths, which those are the personal and digital outcomes from the theory. So here, this is my conceptual model of the self-care and family intervention stroke patient. It's adapted from Dr. Rigo Barbara and Schumann Green 2023. So for the patient part, at least intrinsic factors and external intrinsic factors, which can include motivation, skills, competency, physical ability, self-efficacy, collective function. But the outside factors include social support, healthcare resources, access to resource and service, socioeconomic factors that can include the financial part. So from the family interventions part, that can include emotional support, reinforcement of self-care practice, assistance in decision-making. As I said, because self-care is a neutral decision-making part. Accepting monitoring, facilitating adherence to medications and treatment plan. From the patient part and family intervention part can affect the self-care interventions, therefore can affect the patient outcomes. That include physical recovery, reduce readmission rate, improve quality of life, improve activity of daily living, and decrease risk of secondary stroke and premature death. So there's just a comparison with these two models. So I did some literature overview of the theory I choose to gonna be used for my research study because it's fairly new. It's published in 2023. I have not found any research articles using that theory, but I found quite a few articles using that framework was developed before. So the left one is a research protocol that gonna study the immigrant with type 2 diabetes on self-management and self-care education part. So the study gonna guide the development and testing of a culturally tailored diabetic self-management education program that will contribute essential information about best practice for these populations. So I think this is very relevant to my research topic because I plan to use that theory to study in immigrant population with stroke, like Hispanic immigrant or Asian American immigrant. So the right side is a paper, is a quantitative studies analysis of the use and family management framework. So this paper include I think it's more than 50 papers using this framework. The quantitative studies, there are many disease studies. Like the most popular one are heart failure, diabetic, and cancer. But there's only one paper studies the stroke self-care part. So I think it's a gap for me to study on. That's all. Thank you. Here's my reference. Any questions? Thank you so much.
Thank you, Drew. Very good job. Anyone have any questions for Drew before I get started? Any comments? Okay. As you know, this is right up my alley. I love all of this idea here. A couple of things I wanted to point out to you, Drew, and I know you and I met and talked about your theory initially. Your model, your conceptual model.
Yeah.
This theory. As I was looking at just now, I really like the way that you took some of the comments previously and from when we were talking about this and added that. Could you pull up your model, your conceptual model for us real quick?
Yeah.
Okay. So moving forward, I think this is a great start here. And moving forward, a couple other things that you need to think about when you are trying to kind of further develop your study, thinking about the patient outcomes that you want to focus on in your work, whether you end up doing an intervention as part of your dissertation, or if you plan to do more of a descriptive work that can then feed into intervention development as you get out. You want to think about what outcomes, patient outcomes you want to focus on, because, and this goes for anybody who's, thinking about doing anything like this, you want to consider outcomes that we can easily measure, that can be measured, in a decent amount of time. So things like physical recovery. What does that mean? Physical recovery. Does that mean in a stroke patient that they have their functionality has returned, that they're able to, do more activities on their own? And if so, how are you going to measure that? You see what I'm saying? So you want to make sure that your outcomes that are in your model and that you are putting in your study for your dissertation are things we can measure in some capacity. So, what does that mean? Physical recovery. What does that mean? I have no idea reading this. Reduced readmission rates. Okay, we can look at that. If you were going to do a longitudinal follow-up, you could look and say, okay, if I'm going to do an intervention and then I'm going to look at them after the intervention, then I'm going to look at them 3 months later and so on. I'm going to compare that group to another group. Then you can speak to readmission rates. If you have, say, you're just going to do a pilot of some sort, you won't be able to answer that question. And that's okay. I mean, but this is just things to think about as you're kind of continuing to mold your study over the next few months. Improved quality of life. Quality of life is an easy outcome. Improved activities of daily living. Again, so how are we going to measure that? What does that mean? What is the actual, concept, if you will, that can kind of define that? You can always measure self-care, of course, but, that is in itself can be an outcome or it can be an independent variable. Self-care can go either way. So I would encourage you just to think a little bit more about what other outcomes that are easily measurable. Decreased risk of secondary stroke and premature death. Again, that right there has to be done with a long prospective study. So that's not something you would do in this dissertation. So then that's okay, but this is just a starting point. So I think we need to think about what outcomes are things that you're interested in that have meaning for what you want to focus on down the road, and think about, making sure we'll be able to identify those clearly and measure those. Okay, so just some feedback for moving things forward. But otherwise, I thought it was a very good presentation, and I like the way that you kind of molded components of these two theories together. I think that works very well for this. And I did write down, this is not something you said, but this is something that I have found, and what I know is in the heart failure literature, and I feel like it's in all literature, that self-care behaviors are rarely completed alone. They're completed with a care partner or their family. So I think this is really good that you're focusing on the family in this study. Looking forward to seeing more from you on this. Wonderful. Great job. Anybody else have anything for Drew? Okay, wonderful. All right. Thank you, Drew.
Thank you.
Okay, let's see. I think that just leaves you, Emma. Do you have your microphone working?